we want to start with this article that came out quite early during the outbreak in China, where authors make a comparison of CT and ultrasonographic features of COVID-19 pneumonia. As you can see, there are two main features, both in lung CT and ultrasound, that are ground glass opacities in CT that correspond quite well to interstitial syndrome in lung ultrasound. Interstitial syndrome means the presence of a thickening of the pleural line. Always keep in mind though that the pleural line is an artifact, so its thickening does not correspond to an actual thickening of the pleural that can be seen by CT. So thickening and fragmentation of the pleural line, I would say. B-lines, which can be single, multifocal, or confluent, as in a white lung pattern. And the second feature is are consolidations that can appear both in lung CT and in lung ultrasound. Also, these two features correspond quite well to the severity of the disease, meaning that the interstitial syndrome, if present alone, usually means an early stage of the disease or a mild infection, and the presence of consolidations means that the disease is progressing or its course is running from some time already. This is an example of the CT findings. At day 1, we can see some ground glass opacities, especially at lower lobes, whereas some consolidations are also becoming apparent. And then at day 7, consolidation is what we see most. So about the early lessons that we learned in lung ultrasound in COVID-19. As said, interstitial syndrome is for sure the main feature. It can be focal and mild at early stages. And at these stages, though the accuracy is not the best, it certainly is much higher than chest X-ray, but it is not as high as CT because sometimes the involvement is not peripheral. And in this case, the lung ultrasound can miss the diagnosis. And there are some chances, of course, of overdiagnosis since the specificity of such a pattern is not very high. It might become higher since the pre-test probability during the outbreak is very high. As the disease progresses, then the pattern fully develops, which means a random and patchy distributions of interstitial syndrome with spared areas in between. Spared areas are very classic and very important to assess. Involvement of the periphery, as said, and usually of lower lobes and posterior areas. Then the thickening, as said, and fragmentation of the pleural line, and some subpleural consolidations that might appear. At this stage, the sensitivity is for sure very high, and also the specificity of such a pattern is higher, especially considering the high pre-test probability. Then, as we progress to a more advanced stage, the involvement becomes more extensive, consolidations become gross, and also alterations of the pleural line. Pleural effusions, though, are rare also in more advanced stages, even if some fluid layer can be seen at this stage. Lung ultrasound is virtually always positive. And if we see some pleural effusion, we want to think about differential diagnosis, for example, overlapping heart failure or bacterial infection. Now we wanted to show you some video examples from our COVID-19 dedicated medicine ward, and all the following clips were recorded by myself when assessing patients with confirmed lung involvement by the disease. We start with the A pattern, which means normality of the area we are actually scanning. As you can see, there is a smooth and thin pleural line with clearly visible A lines beneath it. Up to 2 B lines per field can be seen, and this is considered to be still normal and not relevant. Of course, this threshold of two B lines should be taken with a grain of salt, as always, when measuring and counting artifacts. Of course, depending also on the machine and the setting of the machine we're using. Then we move to the B pattern, which means that B lines are now relevant, but they are still less than 50% of the pleural line surface we are scanning in an intercostal scan. So a mild to moderate interstitial syndrome is present, as you can see in these examples. Some little irregularities of the pleural line may be seen, as seen here, or here, or here, and they are quite typical of this inflammatory disease. If the interstitial syndrome becomes moderate to severe, then we see that B lines become much more dense and coalescent, like in this case where clearly a white lung pattern is seen, and also here. The pleural line can become much more irregular and thickened, as is depicted here, and even more in these other examples where the pleural line becomes very regular, thickened, fragmented, in, like here. And as you can see, these B lines are very dense, and they clearly start from subpleural consolidation. Another thing that is very common are spared areas, like in this case where you can clearly see an area which doesn't have any significant involvement, and we can even maybe see an A line here, and then at the left and at the right of the image a clearly dense and intense interstitial syndrome. The same is here. It's in here with in this intercostal space there is involvement, then in this other intercostal space and in this other here the involvement is much less, and same is can be said about here. A lines pattern, here consolidation with very dense B lines. Consolidations can be small, like in this case, little subpleural consolidation, or little bigger one, very little multiple ones, like in this case, or they can be larger and confluent, like in this case. This is the base of the lung where a consolidation is appearing, which is a very quite typical also, place for them to appear. This is a small, bigger one, sorry, with a triangular shape. And this is the so-called waterfall sign that was reported by some Chinese authors. It means that there are very sharp B lines arising from a little subpleural consolidation in a very sharp way, like beams. This is quite a specific aspect of a specific sign for the disease. These are even larger consolidations. These two are at the base of the lungs, which is the most commonly affected area. This other one was a little higher. As you can see, there is some air inside trapped. This is called the air bronchogram, a static air bronchogram, which is very common. As said, fluid effusions are very rare, even though in this case you can see a little thin layer of fluid around the lesion, and that is actually quite common. What is not common in COVID-19 involvement is such a more severe fluid effusion. These two patients were indeed COVID-19 positive patients, but they had an overlapping heart failure, as can be as is hinted by this other clip, where you can clearly see a distended and not dynamically moving vena cava. And this is the same patient. This was another patient, of course. So when fluid fusion is more than mild, then always think about overlapping heart failure or bacterial infection, for example. Now, very quickly about the potential roles of lung ultrasound. We believe it to be an invaluable tool in the hands of the physician who has the care of the patients in their hands. How to use it, though, depends also on the setting that we are using it in. For example, if we are in the emergency department, we want to use it for screening and diagnostic purposes. Whereas in the medicine ward, where quite often the diagnosis is already made, we use it to monitor, to guide therapy, and to stratify the risk of patients, which means telling apart which are becoming worse and which are becoming better. In the ICU, ultrasound can be used to guide ventilation and resuscitation or to diagnose complications. For sure, the operator skills requirement in these different settings is different, such as for screening and diagnostic purposes, sufficient proficiency in lung ultrasound can be reached by a quite short training, whereas for example, to use it for these more advanced goals, it requires more expertise and skills for sure. About the second option, which was monitoring of patients, we want to say that not much robust evidence is out as of today, scientific evidence, I mean, and what is known is basically taken for our experience in ARDS patients. For example, we normally use lung ultrasound score to monitor these patients, which is something that was derived from this article about ARDS patients, where this score was derived by dividing the chest in 6 different areas for each hemithorax: 2 anterior, 2 lateral, 2 posterior, divided by the anterior axillary line and the posterior axillary line. Each one of these 3 areas was divided also in 2 parts, one upper and one lower. And then to each one of these areas, a score is given, 0 to 3, and it is reported in these grids like this. 0 means that we have an A pattern or up to 2 B lines. A score 1 means that the scan region shows some B lines which are not reaching more than 50% of the area of the field of view. A score of 2 means white lung or coalescent B lines more than 50% of the field, and a score 3 means that are some relevant consolidations in the area. For each area, the worst score that we can see scanning, moving the probe around, is given. For example, we start from the right upper chest, anterior upper chest. We move the probe thoroughly as thoroughly as we can, and we, for example, find this pattern, which is given a score of 1, and it is reported in the grid. Then the same is done for the lower part. This pattern would be given a 2, and so on. We at the end reach this, for example, something like this, which is a score of 10 for the right chest and a score of 6 in total for the left chest, meaning that there is a difference between the two, which is quite common. And then a whole score is derived, for example, 16 out of theoretically 36. But now, how to use this number? What is very important in our opinion is what is written here. A higher score indicates a more severe involvement, for sure, especially if anterior areas are affected. But always keep in mind that no specific cutoff values for severity can be given. Sometimes a score of 4 is considered significant, but we still don't know enough about COVID-19 to give an exact number. And also, what is more important than absolute values are changes over time of these values. meaning that if we have at baseline a score of 16 and then we see after a few days of therapy that the last score is decreasing, then this is a much more strong statement than just having one measurement and trying to assess the severity by just one number. And for sure, the opposite is also true. So if this number is increasing, meaning that B lines are becoming more dense, or some consolidations are appearing, that means that the patient is going worse, and maybe we want to consider a more higher intensity of care. So, as said, there is not much scientific evidence, and much is derived from our experience in ARDS. What we know from ARDS patients is that lung ultrasound is quite reliable to predict also what CT would show in these patients, since lung ultrasound is very good to classify the air content of lungs and the tissue density of lungs. So there is a quite good agreement between the two techniques. This is another example of a proposal which was made quite recently by some Italian authors, um, guided by Gino Soldati, which is a master and one of the founders, I have to say, of lung ultrasound. And they propose an international standardization where the chest is divided in 14 areas, not 12, because they consider 3 areas at the posterior part of the lungs. And also the score system is a little different, since a score of 3 is given to a very dense white lung, as in this case, and that since they consider little consolidations to be normal also in score 1 and 2. But as said, independent on which score system you use, as said, it is important to monitor patients and to see how they evolve over time. So this is a last slide showing how we think a systematical approach to interstitial syndrome in COVID-19 lung disease should be done. Always have the clinical picture in mind, so don't forget how the patient is going, and use your clinical skills. Use an extensive exploration technique, which means that you have to scan very thoroughly every single area, and this may take 5 to 15 minutes depending on the patient's compliance and the findings, and use both longitudinal and intercostal scans. Then know your setting, as said. If you are in the territory or in the emergency department, you may want to focus on diagnosis. So just see if there is the patient B pattern, which is typical of the disease, or if there are some other findings that hint at different diagnosis. If you find yourself in the medicine ward, you want to focus on monitoring to know how patients are going and try to predict the evolution of the patient. You can use last score. Each system is fine, 12 or 14 zones. It is important to note B lines and consolidations and their severity and distribution. And if there are any accessory pulmonary features, then if you can, use multiparametric point of care ultrasound, which means have a look at the inferior vena cava. If you can, use echocardiography to assess the heart function, and compressional ultrasound may be also useful, since, as we know, there is some overlapping between COVID-19 and pulmonary embolism. But what is most important is to record changes over time of these findings, to predict how the patient is going, and to know when to call an intensivist and when to move the patient to a more high intensive setting. And with that, the presentation is over. I hope that those of you who are right now approaching to the technique found it useful and that have risen in you some curiosity. And for those that are already experts and using it in their daily practice, I'm really looking forward to join you in the live section to hear if you have any comments on the topic. So see you there. Greetings.